Hello, everyone. Welcome to today's session, The Impact of COVID-19 on Healthcare Management, International Perspectives. This session is co-hosted by the Commission on Accreditation of Healthcare Management Education and the European Health Management Association. I would like to now introduce our two co-hosts, Anthony Stanowski, the President and CEO of CAHME, and George Valiotis, the Executive Director of EHMA. George, Anthony, you have the floor.
Thank you, Chiara. Hi, my name is Anthony Stanowski, and I'm the President and CEO of CAHME, the Commission on Accreditation of Healthcare Management Education. Established in 1989, CAHME actively promotes continuous improvement in the preparation of future healthcare leaders. And we do this first by defining measurable competency-based criteria for excellence in healthcare management, supporting and assisting advising programs to attain that criteria, and then accrediting programs that meet the criteria. And then we make the information readily available to the public, students, and the programs. CAHME accreditation has become the benchmark for students and employers alike that ensure that students are well prepared to lead in healthcare. So CAHME is an interdisciplinary group of educational, professional, clinical, and other health sector organizations devoted to quality improvement of education for healthcare management and administration professionals. Our mission is to advance the quality of healthcare management education. George, I'm looking forward to an incredible session, probably the first of its kind for CAHME and EHMA.
Thanks, Anthony. It's really a pleasure to be collaborating with you on this project here. It's been a real delight to get to know you and your organization better and to work across continents to learn from each other's perspectives. And today's going to be a great webinar to do that. So I'm George Valiotis. I'm the Executive Director of EHMA. And so EHMA is the European Health Management Association, and we have the shared focus of improving healthcare management. We do it in a slightly different approach to what CAHME do, and that's one of the exciting things about today's webinar, is looking at the different approaches. So our approach to achieving excellence in health management is to work with educational institutions also, and the full ecosystem, which includes decision makers, policy makers, healthcare practitioners, healthcare managers. We try and involve the full diversity of people. Now we run webinars, we run our annual conference as a way to bring people together to share best practices. And we're also really involved in European Commission funded projects, as well as executive training workshops. And so we run a really full program. Our members represent people all over Europe. And it's my pleasure to have a couple of members with you today that we'll introduce a bit later. So that's EHMA. And let's move on and have a look at why this session today. Well, we knew that there was a lot of interest in this work, and this session started to look at firstly COVID's significance globally. We wanted to understand the pandemic's impacts on healthcare management, education all around the world. And actually it was CAHME who had started this really interesting research and that we were able to then participate in. There's three key points we're looking at. One, to understand the key management competencies that are most effective for ensuring the health of a community during a pandemic. Two, how healthcare management educators can prepare students for a post-COVID world by using the impact of the pandemic in class materials. And finally, three, discuss how healthcare management programs will change due to COVID-19. Now, most importantly, we wanted to understand how the future leaders in the world's great healthcare system will be impacted by this generation-changing event. So over to you, Anthony.
Yeah, and what we did is we took a very simple approach. We created a 6-question survey, and the survey helped us to evaluate the impacts of COVID-19 on healthcare management education globally. In total, we received 229 responses, representing 150 universities from, as you can see here, healthcare management programs around the globe. So CAHME surveyed our accredited programs in the US and Canada, and we worked with a CAHME Global Fellow to add additional university programs in healthcare management outside of the North America. We also worked with the Association of University Programs in Health Administration to get some additional names to help supplement our list. And finally, EHMA contributed and surveyed its members using the same tool. So the image you see here depicts the countries where we receive responses. Now listen, the goal of this survey is not really statistical significance. We wanted to get a rough pulse of where things are in academia around the globe. And what we're trying to do with this survey, with this webinar, is use our panel of experts that we assembled to help us understand the responses and interpret them. So what we did is we've got 4 incredible experts that we've pulled. We have Dr. Shelly Buck, the president of Mainline Health, Riddle Hospital in Philadelphia, in the United States. Dr. Markku Mäkijärvi, the chief medical officer, the Hospital District of Helsinki and EHMA. Dr. Sandra Buttigieg, the department head and professor of the University of Malta. And finally, Dan West, the chairman and professor of the University of Scranton in the United States. Shelly, let me just first move to you for an introduction.
Thank you, and good day to everyone. Again, my name is Shelly Buck, and I am with Mainline Health Riddle Hospital. I have been a part of that health system for a couple of years now. I come with quite a bit of experience, about 35 years of experience in healthcare. I am a registered nurse by background and training, and now work exclusively in administration, and look forward to speaking with you all today about how we have, as leaders, worked through this pandemic and to share some of the work that we have done. Riddle Hospital is part of the Mainline Health System, as Anthony mentioned, located in the suburban area of Philadelphia and Pennsylvania, USA. Riddle is one of 4 hospitals in the system of Mainline Health, but we also have a rehab hospital that's included in our system. And you can see here from the system's performance statistics on the slide, the number of admissions, employees, and physicians that we have within our system. And as the Riddle Hospital president, my role is to lead our teams to meet our community needs by incorporating employee engagement, disease-specific responses in care, bringing evidence-based practices to the way that we provide care to our patients, as well as looking at our organizational structure and leading the team to create strategic plans and initiatives to improve the overall health for the community that we serve. So thank you. Nice to meet everyone.
Hello, everyone. My name is Markku Mäkijärvi, and I'm the Chief Medical Officer of Helsinki University Hospital. It's a consortium of secondary and tertiary care hospitals, the number of 23. In southern Finland, we cover close to 2 million citizens around the capital area. And we are close to 30,000 co-workers, 4,000 doctors, 15,000 nurses. And I'm, as Chief Medical Officer, responsible for all patient care, the development of specialized care, the introduction of new technology and research, all teaching activities. We are in a hospital, and also responsible for safety and quality and preparedness. My background is specialist in internal medicine and invasive cardiology, and glad to be here with you today.
Thanks, Markku. Sandra?
Hello, good afternoon from Malta. It's a pleasure to be taking part in this webinar. I'm a professor and head of the Department of Health Services Management in the Faculty of Health Sciences at the University of Malta. But I also wear the hat as consultant in public health medicine at Mater Dei Hospital in Malta, which is the only general hospital we have on the island, and taking care of the clinical performance unit but one of the most important tasks is as chair of the Patient Safety and Quality Improvement Team. Apart from that, I'm very much involved internationally. I'm the outgoing global representative at large of the Healthcare Management Division of the American Academy of Management, and of course, a board member of the European Health Management Association. What has COVID-19 meant to me wearing these hats is that it has given us a new perspective, that the future, the present and the future will not be like the past. And I believe that as healthcare managers and leaders, we need to take stock of the present to take care of our future. Thank you very much.
And good day to everyone. It's a pleasure being here. My name is Dan West, and I'm a professor and chairman in the Department of Health Administration, Human Resources at the University of Scranton. University of Scranton is one of 28 Jesuit universities here in the US. In addition to my faculty position, I've also been very actively involved with global accreditation, Global Accreditation Council, tied in with CAHME, and I've had a pleasure of serving on many of the committees, including the Accreditation Council with the Commission on Accreditation of Health Management Education. Also, I've been actively involved in doing consulting work in the healthcare industry through a company, HTC Incorporated. So it's a pleasure to be here with you and to talk about my specialty, which is really global health management. Thank you.
Thanks, Dan. So let's get right into it at this point. So again, we had a very simple survey that went out. First question was worldwide, or the first question was, what was the most important competency domains that you felt were most essential for students and graduates of the programs given the COVID-19 pandemic? And what we found in the analysis was worldwide, critical thinking and analysis and leadership and management were considered the most important competencies in the pandemic. And you could see the percentages of the responses that we received from that. So what I'd like is to turn it over to Shelly, and Shelly, kind of, could you give us some perspective on this from someone who is leading a hospital right now?
Sure, I'd be happy to. First, I'd like to say, I firmly believe that anyone can be a leader, and leadership is not defined by a position. Leadership, is really a state of being, knowing and doing the right thing. So in my organization, leadership called upon the entity and operations team members to create work groups that focus on specific logistics of the pandemic management. We quickly mobilized our disaster response teams, as anyone would do during a pandemic or any type of disaster. So we had that structure in place, but we also established system level teams that focused on the numerous logistics and operational needs that were coming forward as a result of this pandemic. And I think we can all remember how difficult it was to even secure PPE and to get additional staff to help us manage and run our operations. And so, we were receiving and collecting a tremendous amount of information from a wide variety of sources during this time. And some sources we could trust, and others we had to verify. The expectation was set to coordinate the information that was moving very quickly, coming in and out of our system, and to share what we found to be facts. Our leaders displayed the core competencies that are required for success while managing a crisis, but also in everyday management of the organization. And so critical thinking and analysis, I'm not surprised that this was one of the top 3 leadership skills that are required, because the amount of information that was received from sources such as the Center for Disease Control, state hospital associations, regional healthcare collaboratives, county health departments, various state federal agencies, the news, our community partners, and even our staff, and the list can go on and on, was quite overwhelming in the beginning. And so you had to look at this from a critical, through a critical lens, and take the time with your experts, if you will, within your organization, and this is what we did, to analyze all of that information. And because we were all learning every day during this unprecedented pandemic, it required the team to do deeper dives into the data and the information that they were receiving, and to make recommendations to ensure safe practices and care for our patients. And this team included a multidisciplinary team, members such as our infectious disease physicians, our quality safety improvement officers, and our team, and many, many others. Clearly written policies had to be developed, multiple dashboards that captured everything from COVID admissions to outbreaks in congregate living facilities. So those are senior housing facilities and facilities that care for those individuals with disabilities that surrounded our hospitals. We collected data on the rate of infections in those facilities, but also we collected the number of deaths that resulted from this pandemic in our dashboards. So the team reviewed the data, they looked at the trends, they collected both qualitative data obtained through conversations, through listening sessions, through rounding with our staff and with our physicians on a daily basis. And we shared this with our teams. We shared this information with our board members and with our physicians in full transparency on a regular basis. So as I mentioned, communication is huge when you're talking about running an organization and mobilizing your teams and helping to fill in those gaps that can create anxiety, stress, fear, derailment of operations, and a lack of trust. And as I mentioned earlier, it was critical to our ability to successfully manage through this pandemic. For weeks, we found ourselves holding 6 huddles a day, and I do mean a day, 5 to 7 days per week. We were on calls talking about the quickly changing environment and how we could best manage through this time. So one of the teams we redirected to focus solely on the communication for this pandemic. And that didn't include just our communication experts and marketing experts. No, this team, as I briefly mentioned, included our infectious disease physicians, medical experts, including OBGYN physicians, and other specialists that felt as though their unique population that they care for may have a need to modify some of the information and data that we were sharing. Multiple sources of information was created to guide our leaders and to consider as we managed through. And because of the information, was changing so rapidly and sometimes appeared to have conflicting, sources, and some of the facts were actually conflicting, it was quite difficult, but we managed through and were able to share our information in multiple settings, as you see here, and through multiple modalities. And this included putting a COVID-19 or coronavirus 19 link on our internal webpage, our intranet page, that anyone could access 24 hours a day, 7 days a week. We held town hall meetings, which we recorded so that staff and physicians, both physicians that were employed with our facility and our system, but also those that are independent in practice and just collaborate with us and partner with us, could access this information whenever they needed to get the information. Toolkits with resources, streamlining the multiple pieces of information that we were receiving, because during this time, we all recognized that there was a heightened amount of stress and anxiety, and people needed bulleted points of information, not long, paragraphs to read and try to decipher. So Zoom meetings, WebEx, daily operation huddles, and you can see the list here, all were part of our communication plan.
Shelly, thank you. I think, what I got out of this is you over communicated, and I think in a very positive way through multiple vehicles in multiple modality type of approaches.
Yes, absolutely, we did. We had to ensure that we were connecting with people from our board to our community members, to our staff, to our physicians. It is critical. And I think we've heard a number of times during this time, in the absence of data and facts, people will make up the story, right? And so when you're leading an organization, you don't want that story to be made up, because it can create even more stress and anxiety. And the team, you want your team to really be, as we say, locked, arm in arm, and moving forward in a succinct and clear, concise manner, so that you can deliver the highest quality, have the safest outcomes, and an engagement that helps to further drive those expectations.
Okay, so I might jump in now then, and let's have a look at what happens next. So what this slide shows is some of the research of the outcomes of the research, and then I'm going to just speak to it for a moment, and then I'm going to go to Dr. Mäkijärvi, who's going to give us some of his experience of how this relates. So before Dr. Mäkijärvi, I hand over to him, I'll just explain this slide. So pre-pandemic, most programs surveyed, so 59% reported being face-to-face. Hybrid programs, you'll see, were in the minority, with only 17% reporting part of the class being virtual and part being face-to-face, and 24% were mostly online programs. So then, of course, during the pandemic, things shifted and most programs went totally virtual, 87%, with only 11% being hybrid, and almost none were face-to-face, of course, in this period. However, the expectation post-pandemic is that totally face-to-face will not regain its leadership role. Only 33% of programs will go back to mostly face-to-face. The percentage that will be staying all virtual will roughly return to pre-pandemic levels at 28%. However, 40% of programs are expected to be a hybrid. So Dr. Mäkijärvi, what do you see as being the most significant impact on this change? Will it be impact students' competencies? With the move to more online content versus in-person, do you think this is going to affect the critical thinking and analysis skills that students have?
Thank you for those questions. If we look at the situation before COVID pandemic and during and after, for example, here in Helsinki Medical School, before COVID pandemic, teaching was 100% face-to-face. 10% lectures and 90% either small groups or personal face-to-face teaching. During the pandemic, all the lectures were moved to Zoom, and this face-to-face practicing at hospital was reduced heavily, not totally stopped still. And during the autumn, we could increase the presence of students in hospitals, because the COVID situation in Finland after the first wave in March and April was pretty good till almost Christmas. The second wave came during Christmas, New Year, and the third wave during Easter. During the autumn, however, we could use recorded lectures, and then you could present questions live using your personal iPads, and then we could organize digital visits to different departments of the hospital. All the exams were digital, also logbooks, and practically we got rid of all paperwork in our faculty. I reckon that this experience from COVID pandemic, those situations will lead our faculty, our ways of teaching and the programs to kind of a hybrid model, something like 30% to 50% digital. What's the meaning of this? Well, if you look at how I work nowadays as the Chief Medical Officer and the current leader of our COVID pandemic work, I would say that this kind of a hybrid model is just right. That's the modern model, how to lead a hospital organization nowadays and also in the future. We utilize a military type of escalation model for different levels of meetings, and the data collection is fully digital. We share the same picture, all the leaders and managers, and very few meetings still now are face-to-face. I'm sure we go back to that direction after the second vaccination. Hopefully there are no more deadly variants coming up from India or other direction, hopefully not. But I would say that although it was cumbersome 1 year ago to organize teaching and different programs, we've learned a lot. We really took a giant leap in digital way of working, and actually that's the best way of lead and manage hospitals now and especially in the future. It's much more effective, it's much more democratic, much more equal, and also this sounds kind of funny, but you meet more people with this way. You just have to learn how to use these new digital tools. And there is still some work to do, but if even I, as 60 plus hospital leader, can learn it, so I think everyone can learn it. Thank you.
Thanks very much, Dr. Mäkijärvi. So just if I could pick up on something you've said, it sounds like what you're saying is the way that education is happening now in that hybrid model is quite ideal. And do you think then that the students that graduate from having been inducted into this hybrid model from the start will produce better quality health managers, better suited to the current work? Or do you have any things that you think will need more attention that we couldn't teach properly because of the hybrid nature?
I think this hybrid model will be the winning model, but there have to be some parts carefully being taken care of, like when you do innovation and development work, or when you deal with very difficult problems, then in order to reach real good results, you have to pay attention that a digital meeting or a hybrid meeting is not a regular meeting with only with agenda. There is a very big responsibility for the chairman or the chairperson, or also for all the members, that they really put some effort and additional value into this common work and for common goals.
Terrific. Thank you for that extra insight, and we really appreciate you finding time in your schedule to share your experience today.
Thank you.
So Anthony, back to you.
Yeah, so the next question that we asked was about how were programs challenged in placing students in real world experiences? And 58% of all programs said there were some challenges and were some significant challenges in placing students in real world experiences. Others kind of talked about the issues in terms of engaging practitioners in the curriculum, and then a variety of different impacts that they found around creating experiential learning opportunities for graduates or for students. Dr. West from the University of Scranton, do you want to comment on this? What do you think the impact will be on competency development with students with less opportunity for real world experiences? And I think, one of the other questions I want you to address is, have you heard of innovative experiences that programs did to kind of help get over this?
But a very good question, and let me try to talk about some of what I consider the critical pieces here. Most of us in health management education more strongly embrace competency-based models. And so I think one of the things that happened with the pandemic early on, but then began to smooth out, is that our ability at implementing and having application integration and assessment of knowledge and skills got interrupted a little bit in several different ways. For example, study abroad programs, short-term, long-term, came to a halt. So that people that were looking to develop competencies in global health management, by working in other countries, that was interrupted. What we also saw was that depending on the type of program, whether you were an online program with more of an executive focus or a residential program, there were also some interruptions to having applied projects brought into the classroom because healthcare organizations were restricting access to students in these applied settings until they were able to manage what was happening with COVID. But it also had some impacts in mentorship relationships. And importantly, we rely on preceptor evaluations in residencies and fellowships as providing very important feedback to students and to faculty running programs as to the competency level of their students. And this was interrupted. So this is where I think as things began to smooth out and change, and we had a better understanding of COVID and what we needed to do, we were noticing more students were back in applied settings, which was a phenomenal learning experience. As was talked about earlier, what has to happen with teams and communication and being concerned with the health of our own employees within organizations. And the other thing too is that we began to relook at short-term study abroad opportunities that may be available. They're back on the drawing board as universities are opening up again. We're seeing that there's receptivity here to global travel, international travel, which I think will again enable us to try to catch up. But there's no question that we couldn't capture everything remotely, virtually. You try to do the best that you can. You try to make the alterations in the curriculum to be able to accommodate it. But, having what I call boots on the ground, those types of experiences are extremely critical to professional development. And so I think we were challenged as to how to best do that in our graduate programs of study.
Best practices. Have you run into other universities who have done some innovative things to kind of get around the not being able to be on site?
Yeah, some of the local healthcare providers were able to virtually get engaged with programs and become very strongly involved in the teaching process. Even though it was being done virtually. And so they were able to take our students into certain areas and be part of certain meetings and discussions, because, as you're trying to teach governance and leadership and patient safety, you really need to hear these quality circle discussions that are going on. So some providers were willing to do that. And we could bring that right into the classroom, and that was important. And then some of the senior executives were able to debrief our students. So it wasn't the real thing. We weren't inside the four walls of the healthcare facility, but we were there, and we began to see how we could use that modality, as was mentioned earlier, how these hybrid modalities can in fact be used if framed appropriately. So that's an example. We also found that on executive programs, because they were already employees of healthcare organizations, they were on the inside. They were able to do certain things that other residential students couldn't do. And so again, in the virtual classroom, we could share those kind of experiences in a very applied way. And that was very helpful to some of the younger people in first year of graduate studies, as opposed to those that are in the residency phase, fellowship phases. And so there's this cross-fertilization backwards, if you will, to the earlier classes. That's a model that seemed to have traction and have worked well. So we were trying to be as creative as we could be under the circumstances, and I really looking forward to some of the post debriefings and some of the studies that'll be done. You know, that'll be collecting some of the best practices and some of the scientific data here. You know, as we take a look back, I think it'll prepare us for future events that are going to happen. There's just no question about it that we can learn from this.
Okay, so I'll pick up here on the next slide, and I'll just speak to this slide for a moment, and then I'm going to introduce back to Sandra Buttigieg, who is going to speak to a few slides that she has. So if we look at this slide, it shows that worldwide, 31% of programs decreased students in their program, 44% stayed the same, and 25% increased. So Sandra, do you think this decrease will impact the quality and number of people that go on to lead healthcare organizations? What can these nations of the world do to address this?
Okay, so, well, first, I believe that we need to distinguish between undergraduate courses and postgraduate courses. In the case of, let me start with undergraduate courses first. The pandemic, when it came on us in February, March, in Europe it was February, March 2020, we needed to take stock of our resources. And one crucial resource was actually to involve students. Now that may, and in some instances has interrupted their normal schooling programs, their normal academic programs, but they gave them an insight, a very important insight into the challenges that the health systems had to face in setting up public health and healthcare management COVID-19 response teams. So if you click on the slide again, George, I think that is something that happened. What were these huge challenges? They saw that people needed to talk. We couldn't stay in silos in our comfort zones. And one key issue that these students were noticing was the constant public health advice and economy trade-off. The second was, how could we get ourselves talking better, communicating better, and not just within health systems, and therefore involving the departments within health systems, that is clinicians, with health managers, with public health people, but also with other sectors. We needed to talk with people in education. We needed to talk with people with police, justice, government level. And of course, all this, the retraining, the reskilling, the changing work patterns, we needed to form teams, and that is a challenge in its own right, the forming, storming, norming and performing, as we all know, the use of technology. So students were engaged, were actually involved in setting up of these teams, as did the healthcare professionals who are following postgraduate courses in healthcare management. They were also noticing that the stress, you know, we need to take care of the challenge of stress, psychological strains, eventual burnout. What did all this give us? It actually gave us a very positive outcome, that public health and healthcare management have become more recognized by both undergraduate students as well as clinicians and healthcare professionals who are either following courses in management, but also those who intend to follow. So I think this has been a great positive outcome. Maybe if we go to the next slide. And indeed, this, all these people who were working in the comfort zones, and like clinicians, sometimes we have this, I don't know whether it's in Europe, but sort of the clinicians say, okay, we only talk to the healthcare management when we need to, but here they needed to. So everybody understood that we need to work together to solve this wicked problem, and the wicked problem being the COVID-19 pandemic, with its evolving things along the way, including the variants, etc. So positive outcomes that students might have seen, and healthcare professionals, clinicians not used to healthcare management practices, they understood that we needed to work in teams with optimal communication. We needed optimal communication. And we needed to be well-functioning teams. We needed to become resilient, coping with stress. Something happened during COVID-19. There were regular meetings. And when I say regular, there were at times daily meetings. People got together either virtually, some in hospitals we had to do face-to-face and using auditoria to keep a distance, but they were meeting because they needed to take stock of daily evolving things, and that was important. One other thing is that we learned to share not only bad news, sometimes like when our ITUs were full up, and that was bad news. But then when things were getting better, when our vaccination program was doing extremely well, we started to celebrate success. And this was all for the students to see, you know? So maybe those percentages, George, that you showed us could well be a snapshot. But I strongly believe that COVID-19 gave us an investment, which eventually we will have the return on that investment, that we will see more people, be they graduate healthcare professionals or those that want to follow undergraduate programs, to actually start taking health management, public health issues, risk management, patient safety more seriously. Maybe we can go to the next slide, which I borrowed from our Ministry of Health, which is a very nice picture, because it shows that COVID-19 is a complex issue. It has been a complex issue. And whereas we were talking about waves in terms of the infectivity, there were other waves going in the background. The first wave is the panic, you know, we needed to respond very, very quickly. The question of the resources, the importance of critical decision making, how to make best use of your resources. Then we started to see other waves, like the impact of resource restriction on urgent non-COVID conditions. So precedent, you know, it's the importance given to COVID-19 at the expense of non-COVID conditions. And people were seeing that. These are experiences that clinicians started to say, well, this is an issue of management and leadership. We need to take these seriously. We cannot just say, well, we are clinicians, so we are not used to taking management decisions. The third wave was the impact of interrupted care on chronic conditions. And now something that all of us have to face. And I believe that this is the importance. I've had people who are seasoned clinicians, you know, pediatric surgeons, obstetricians, gynecologists coming to me and following courses because they've understood that this is something that required more than their usual clinical training. And indeed, something that should come out from today's webinar, please go to the next slide, is that we can collaborate together. Here we are a group of people coming from different countries, from different continents, and indeed, this initiative, a research topic that I, together with colleagues from Australia, UK, Sweden, have launched, is an initiative that came as a result of virtual roundtables between continents. US, Europe, Australia, you know, and we came up, let's look at health service management and leadership COVID style. And I invite people who are listening to us to submit an abstract and a manuscript. I would like to end this by, I would like to quote from an editorial penned by Stefan van den Broek in the Health Promotion International. Confucius, in all his wisdom, believed that it is the study of the past that helps to define the future. But in the current situation, it may well be the present that gives us directions in which to look forward. And indeed, as healthcare managers and leaders, we need to take this opportunity. This is an opportunity. It was bad news for the world in terms of many things, including economy, having to stay inside, social distancing, etc. But from a healthcare management and leadership perspective, this is a window, a great window of opportunity, which I believe will have a great deal of return on investment in people showing interest in the specialities of public health, management, leadership in healthcare. Thank you.
Thanks, Sandra. So that was some great information, and thanks for all that detail. What it leaves me wondering is, when we started with saying there's going to be fewer students, that there are currently fewer students, smaller intakes, and I like the way you're framing it, that people are using COVID to create opportunities. Do you think then, are you expecting to see greater investment specifically in health management, or do you think that most funds will be diverted into clinical roles or other roles? Like, how do you see the job situation changing in time?
Well, as I said, the percentages you've shown, they were a snapshot during the pandemic. So that could be the result of people having to face so many challenges during the pandemic, like staying inside, you know, not taking the risks to attend classes, if classes were face-to-face. Of course, some were virtual. But now, present and future is that clinicians themselves are saying that the training that we receive in order to become surgeons, cardiac surgeons, pediatric surgeons, obstetricians, physicians, cardiologists, it is not enough. In this world, the pandemic is showing us that we need to become well-versed in management, leadership, critical thinking, because in their job, they have to do this critical thinking, critical decision-making. Ethical issues, for example, were very much something that were on a day-to-day basis, you know, and their clinical training is not enough. They've realized that they have to lead, that they have to manage, that they have to get the best out of people. You know, we have the transformational leader that inspires, motivates, even during times of stress. And I believe that clinicians now are thinking about furthering their studies, not just in their area, but also in management and leadership. They've understood the importance of skills. So the answer to your question, yes, I believe there is a positive future for all of us in healthcare management, that we will get people more interested in what we're doing.
Beautiful. A great way to really segue into the Q&A. So Anthony, let's build on that, shall we?
Sandra, thank you very much for those comments. I think, you know, your concept of investment in that COVID has kind of caused, and I think the opportunity that you talk about, which is the realization from all the people of the world, we're all connected, and we have a responsibility to each other. And it was just beautiful what you said, and thank you for kind of sharing that. I want to ask either Laura or Chiara if they want to give directions for people to ask a question. And I do have one question that came through on the chat. So if you could just kind of describe for people how they would ask a question again, and then I'll go to the first question for the panelists.
I can do that for you.
Thanks, George.
Anthony. So what I'd say to people participating, and we've got 170 people registered for today, and I can see there's still a good number of participants in the room, is the easiest way is to type your question into the Q&A box at the bottom of your screen, the one specifically called Q&A. If you wanted to ask it live, we can also enable that. You can put your hand up using the raise hand icon, and we can activate your microphone for you. And those are the two best ways. Back to you, Anthony.
Great, thank you, George. So the first question that I saw talked about remote learning, and we discussed remote learning in an educational environment, but how has the acceptance of remote learning been a challenge at facilities, like at a hospital or a health system? How has the acceptance been a challenge, and how have you overcome that challenge? Shelly, I'll kind of pick on you.
Sure, I was since I'm not leading a academic organization, I thought I might have to be the last to speak here.
Yeah.
But, I could say it's been quite challenging because we have of course, being in a hospital, we have opportunities for nursing students, physician assistants, nurse practitioners, all of the other allied health professionals, opportunities for them to come in and have their clinical rotations in our facilities. And so in that case, it's been quite difficult for them. And what we've had to do is recognize that some of the new graduates that we would hire would need extended orientation or training because they weren't, given the amount of time that they would have had in their last year and a half worth of training to have on-hand care for the patients that they're taking care of. So we've had to modify our onboarding and orientation program as a result of that. The education that we provide, though, for our staff internally, so the annual competencies, that review quality, safety, just the basic policies that most hospitals and most hospitals and healthcare organizations are required to have, and they mandate for our staff. Some have been very, very well received as we've converted to an all online learning platform. Some are still in the midst of development because in those education sessions, I would say the gem and the beauty of the education is gathered through the face-to-face conversation and not necessarily just through reading PowerPoint presentations or listening to a voiceover PowerPoint or Audible. So we are adapting our learning platforms to incorporate, Zoom and virtual meetings in addition to the typical PowerPoint presentation education that we have. So it's a work in progress. I don't know that we figured it out yet. We partner with a number of different academic organizations within our service areas and take their lead and share what ideas we may have, and then vice versa. So that's how we're trying to handle it. But so far, so good. I'll say that. Thanks,
Shelly. George, I see a question from Antoinette. Do you want to read through that one?
Sure. So Antoinette Epps, thanks so much for joining us. And your question is, what are the most important lessons for health administration faculty from COVID and the survey findings? So since this is to the survey findings, Dan West, I wonder, are you someone that knows the survey findings that I could ask this off to start with?
Yes, I'd be glad to comment on that. I think overall, faculty have found themselves more challenged this year, both in terms of the modality for teaching, but also designing into the curriculum and courses higher level learning opportunities. So that, the biggest thing is this flexibility to be able to change our courses quickly. Healthcare calls it pivoting. And it is a pivoting in academia where, we've got to change things quickly in the program to catch up. I appreciate, for example, Shelly's comment here. I was at a hospital board meeting this morning, and the biggest concern here was how we were managing early careerists in the nursing profession coming in. Because we realized that their clinical training experiences had changed dramatically. And as Shelly noted, we need to provide additional education here. and support systems so that we retain young nurses into it. So I think, faculty need to think not only what are they doing in the classroom, but what are the partnership opportunities with the healthcare industry? Because here again, I think faculty can be helpful in doing some of the teaching that may be done for management in the applied setting. And, so there, I think, are unique opportunities here that we normally don't sit and think about. But these are very creative opportunities. It's a time for change in how we teach.
Thanks very much.
I'm sorry, George.
Oh, no, I didn't mean to cut you off. Did you want to add something more?
No. Thank you for the opportunity to respond to that.
So what I was going to do then is also look to Dr. Buttigieg and ask, you were nodding along with Dr. West, does that resonate with you? Do you have anything different that you experience?
Yes, of course, yes. This year for faculty, the way that all courses, not just our courses, I mean in management, health management, but all the courses, we had to get reskilled ourselves many times, because if we were delivering most of our courses face to face, then we the universities in terms of their administration and support structures, they had to train us to be able to be of better service to our students. And at one point in time, we were faced with so many platforms, to use and how to best use them. Also, when examinations and the way assessments were carried out. So all these things were a huge challenge. However, I believe that in particular, those members of the academic staff who also are in some way hands-on, still practicing, they perhaps were better in providing stories and things that were happening on the field, but maybe were more challenged in using technology. On the other hand, you had to have this balance. On the other hand, the pure academics then were very much concerned to get up-to-date information on how to modify their teaching in order to be more up-to-date with what is happening, because the world has changed, whether we like it or not, in particular in subjects related to healthcare professions. So something that I found in my department that helped was to consistently adapt and get people into breakout rooms when we were using virtual means to apply theory to COVID times. So we added that extra bit, and some of the participants in the classes are themselves healthcare professionals, so they came back with stories. So it was a live thing. We needed to be agile in the way we respond to the huge challenges that COVID gave us. But again, I like to be positive. It gave us huge, exciting, and new opportunities. Not perhaps moving a bit, sort of the usual became boring, and COVID became exciting, And I think that was really, really great for those who went along with it. Because, of course, those who said were negative and said, oh, this is all negative, then that is a problem.
Thanks, Sandra. That actually makes me want to turn to Anthony for a question. Anthony, I know you're not a panelist, but in hearing about Dr. West's reflections on pivoting. I don't know if that was Dr. Buck actually who mentioned that, but maybe you all kind of talked about this agility and this pivoting. Maybe that was Dr. Buck actually. How does that fit into accreditation then? Like, does the need of the workforce to be so agile, how did you guys factor that in an accreditation framework?
Yeah, it was really fascinating how quickly we moved when the pandemic hit, to kind of make sure that we can still accredit programs. And we created a whole virtual accreditation process to kind of make that occur. And we've implemented that and continue to evaluate it. And then we're going to figure out what we need to do with accreditation post-pandemic. The thing is we can't go back to the way we used to be, because it had all of its flaws and errors within that. And we can't stay with what we're currently doing during the pandemic. Where do we go from here? And I think that's fascinating. So that's a little bit of the operations of accreditation. But George, I think the question you asked was probably a little more important about that, which is, what does it mean for the students that are coming out of our programs? And how do we as accreditors really kind of work to make sure that the students are well prepared to lead in that world post-pandemic? And that's one that we're studying as well at this process. We've assembled a really interesting group of people led by Harvard Business School's Reggie Herzlinger to kind of look at innovation, and not just innovation in healthcare, but innovation in healthcare management education. And that's an exciting part that we're in process of doing and working with our folks on. And then we continue to revise and update our standards over time. Thanks for that surprise question, George. Good. Okay. So, again, everyone, thanks for everyone who listened in for attending today.